so serious photo of myself because I'm not so serious. So this was during the Heartland tour, which is a big bike ride around the province that Jack and Antonio has organized for the last 14 years or so. So thank you to Crohn's and Colitis, first of all, for inviting me to do this. I think I did a talk in Calgary when I was a fellow to a similar group, so I'm more than happy to come back at any time. So, and especially for a topic like this, talking about intestinal ultrasound. So when you first say this, and I'm glad to hear that it's becoming less common, to see this face of like shock and surprise and awe, both from healthcare professionals and also patients when you say this, because probably 5 years ago and at least 10 years ago, if you said this, most people would look at you like you were crazy. Because most people don't think of ultrasound as a standard way to look at the bowel. And especially now when you have an ultrasound, you think of, you know, for obstetrics, for babies, for looking at your liver and your kidneys, and it's not really something to look at for bowel. So I'm hoping by the end of this talk I'll kind of convince you that it is a good thing to do. And it is something we should be widely doing in Atlantic Canada and in Canada. So I have 400 slides. I hope I can make it through 30 minutes. It's talk really fast. So we'll just flip through things. So what is intestinal ultrasonography? What's the benefits of it? So it's a non-invasive method, first of all, right? So we're not doing anything to the patient. We're putting some lube on, which is nice because you get a nice moisturizer. It's a non-invasive test, not like other tests that we do, right? And in my practice, we're using it for inflammatory bowel disease, although we can see other things. Obviously, it's very safe, right? You'll always hear the one or two people who say, should we be doing ultrasounds on pregnant women? It's very safe, right? There's no preparation, right? There are some preparations we can do to enhance the accuracy and the sensitivity of the test, but for the most part, I don't do any preparations for patients. And there's no radiation, right? So unlike CT scan, there's absolutely no radiation, which is huge and something we try to avoid. It is a very effective method compared to CT and MRI and endoscopy, although there are strengths and weaknesses with it. And the point-of-care testing is really the key thing that's really valuable when your gastroenterologist can do this while they're seeing you. So for those nerds amongst you, or those of you who want to read kind of more evidence-based stuff, the European Crohn's and Colitis Organization guidelines are excellent, and you just have to search ECCO guidelines. It's the first link, and it's very scientific, but if you want to read through those, they're excellent. So what do the ECHO guidelines say? So how do we diagnose Crohn's disease or inflammatory bowel disease? Well, there's no one test, right? It's not like low thyroid where you can check the thyroid level. There's no one test, right? So it's a whole, gestalt kind of approach. So it's clinical, it's biochemical, it's blood work, it's stool tests, it's scopes, it's imaging, and pathology, biopsy. So it's a whole slew of things. It's not one thing that we do to diagnose Crohn's disease. And traditionally, we've had these tests beyond endoscopy. We've had a number of different tests. In the olden days, we had small bowel follow-through, which is kind of fallen by the wayside. So the old barium tests, which really aren't that sensitive and they're not very pleasant to have done for those of you who unfortunately have them done. We have great tests like balloon enteroscopy and capsule endoscopy, although they are limited by the preps and they're still invasive. We have traditional imaging like CT scans and MRIs, although they have their downside, including radiation, the cost, the accessibility. And then last, but certainly not least, is ultrasound. So just to kind of lend some evidence or some support to what we do, we have an international bowel ultrasound group, which is very active. It's consisted of a number of members throughout Europe, Canada. We have one member in the United States right now, but hopefully that'll grow. Throughout Eastern Asia and Australia. And there's a formalized course right now to actually learn how to do this. So it's a 3-day introductory course with experts, with the real people and patients and simulators. And then there's a 4-week, two-week kind of apprenticeship, you would say, where you document cases and learn. And then there's a final kind of exam from there. So these are all the countries that are involved right now. And these are kind of across Canada where we have gastroenterologists who are doing this. There's a few places where radiologists are doing it as well, but this is mostly where the Canadians are. So you can see there's a bit of a gap there in central Canada, but we're hoping to improve on that. So I won't show much evidence or like hard, studies or anything like that. You can go and read about that. I think this talk is more just an introduction of what ultrasound is and how I came to kind of start doing it here. But you can see from this is a kind of a meta-analysis of a whole bunch of studies looking at how sensitive ultrasound is compared to doing things like white blood cell scans, which we don't do as much, CT scan and MRI. And you can see there that the sensitivity of ultrasound is about 90%, whereas we know CT scans of the bowel are about 85% sensitive. MRI is more sensitive, but it's certainly the cost and accessibility. So we can see that ultrasound does have a good sensitivity and specificity. It's a good test. It's not just something we can do, it's something that's a good test. So what are we actually looking at, right? And this is one of the beauties of ultrasound as well. You can see it, right? Your patient is sitting right there with you, and you can look at it together. Unlike endoscopy, where you kind of show them the pictures afterwards and you're kind of groggy and sedated, here you're sitting there together and looking at things. So we're looking at, so this is a colon here, and so you can see kind of the folds of the colon, those haustra, those bumps, right? And we can't see through gas on ultrasound, so it's this. You would just see black on the other side. So we only see one side of the bowel. We don't see the inside kind of lumen unless it's filled with liquid, because ultrasound waves don't go through gas. But we can measure the, I don't know how to use a clicker. There we go. So we can actually look at the bowel wall thickness, and we can look at the different layers of the bowel. So you can see there the mucosa, the submucosa, the muscular layer of the bowel. And we're talking about 2 to 3 millimeters of thickness, right? Very thin areas, right? So we need a very good machine to do this. We need some good training to do this. Because it's not like you're looking at a kidney or a liver that's 10 centimeters in size. You need a really good high quality machine to see this. So this is just some of the guideline kind of statements about what we should do with Crohn's disease patients. When I went through my training with Ian around the same time, the standard kind of statement was, once you diagnose somebody with Crohn's disease, you should have a full kind of assessment of their gut, right? So if you think they just have disease in one spot, you should look everywhere by doing ultrasound, by doing an MRI, by doing a capsule, and that will really depend where you live and what you have access to. And that's obviously different all across Canada. And it's, doing some of these clinical and biochemical tests, which should be a standard thing that we do. And when we treat people with whatever we do, with enteral nutrition, food, with drugs, with whatever we do, we should reassess, right? And we should get objective measures of inflammation. We just should objectively reassess. We should see how our patient's doing, but also how their gut is doing by doing one of these methods. So with ultrasound, we can see the gut either in a kind of an axial view or in a longitudinal view. So that first picture here, so in the picture on your right, it's kind of looking down the tube, right, the axial view, and then we literally just have to turn the probe, and then it looks at longitudinally, so you're looking at the bowel like a hose, right? And here, this way, we're looking down like the pipe. Oh, sorry, keep my finger on the one button. So what's the utility in clinical practice, right? So we can initially evaluate people who come in, we think they might have Crohn's disease or colitis. We can follow up for assessment of their disease, and we can monitor them, right? One of the original slides said quick and easy. I don't know if it's easy. It does take quite a bit of training. It does take a bit of time. The usual scan to do a full kind of bowel scan is about 20 to 30 minutes. So it's not a quick and easy kind of thing unless you're just looking at one specific area. But it is non-invasive. There's no preparation. There's no sedation. It's very inexpensive compared to other tests that we do. There's no radiation, and it's a real-time kind of assessment, which you'll see some cases here, and you'll see what a real-time assessment is. So what are it's not all the best thing in the world. There are limitations, right? And I always tell people, if somebody tells you it's the best thing ever, kind of slowly walk away, right? There are limitations in everything we do. So definitely the upper kind of gut, it's hard to see, right? Like the very upper kind of small bowel, it's hard to see. The rectum we don't see at all, right? It's so deep in the pelvis, we just don't see it that well. There are other ways that we can see the rectum and the perineum, but it's hard to see it just with abdominal kind of ultrasound. And then sometimes, depending on the person, it's all gas filled, depending on the location of where the bowel is. And people who are really obese, it's hard to see bowel. and then obviously the operator kind of expertise. But this is kind of an endoscopic picture on your left of what a small bowel and ileum looks like. And then you can see this little paper-thin kind of area here. It's normal kind of bowel. It's interesting, I had a medical student this week, first year medical student. We did some ultrasounds together. I think it took her 4 ultrasounds to start recognizing where things were. 4. It's pretty good, right? She was brilliant, but she was very good. But 3 or 4 scans per year medical student. So to become an expert, yeah, she'd probably do a couple hundred. But after 4, she was actually recognizing where things were. So this is a very abnormal bowel. So you can see that big, black, thick layer there, with that arrow sign. Make it easy and put an arrow. And this is somebody presumably with Crohn's disease who has a very scarred bowel that has a lot of inflammation that's all turned to scar. And that little thin white layer in the middle is the lumen, or where the gas is in the middle of the bowel. So we can easily see that on ultrasound. And then we look for other things like fat outside of the bowel and how bright it is. If it's bright, it's more inflamed, so we can see that. And then we can see the lymph nodes there as well. So those are all things we look for. And then we also look for blood flow on ultrasound, because the more blood flow that's going to the bowel, we presume it's more inflamed. And we know when people get treated with steroids, when they get treated with other medications, that instantly, within days, there's been studies in Calgary where they brought people back daily and done ultrasounds. And I don't think anybody would do that for colonoscopy, but people would do that for bowel ultrasound, right? And you can see this inflammation just dramatically decrease over days, right? So it's a very helpful test that's very responsive. This is just another slide of the color. The other beautiful thing with ultrasound, besides the patient not being sedated and actually being right there together seeing it, is you can evaluate motility, right? You can actually see what the gut is doing. You can watch the small bowel move, right? The colon doesn't move at all while you're doing the test, but the small bowel moves. So you can actually sit and watch. And for patients that we do endoscopy on and they have a little stricture, we say, that's not too bad, it's just a little stricture, it's a little narrow, that's not too bad. And then you look with ultrasound and it doesn't move, right? And the bowel doesn't move at all. Then you say, oh, that's why you're so nauseous. Oh, that's why you have so much pain there. Even though the disease is under control and there's no inflammation, you still say, oh, that makes more sense, because the bowel just doesn't move properly. And this is normal bowel motility here. We call it happy bowel, right? It's moving around. So, and it's interesting when people eat, the bowel is just flurrying around, and I can tell people in the morning who haven't had their breakfast yet, I tell them you have to eat breakfast. So we can see strictures on ultrasound as well. So you can see you're all experts now. You've seen 3 or 4, but you can see here this content is just not moving through very well. You'll just see a little splash of kind of liquid move through there, and it's not that nice happy bowel that's moving properly. So you can barely see any liquid moving through there, right? And then, unfortunately, people can get complications of Crohn's disease where the outside lining of the bowel can become so inflamed it touches something else, makes an abnormal tunnel or connection called a fistula. And they can form between 2 pieces of bowel, they can form to the skin, they can form to other areas like your bladder or unfortunately your vagina. And these are all just kind of stock pictures that we have from our group. I'm not showing any pictures from my own practice for kind of confidential reasons. It's a small place. But this first slide shows an enterovaginal fistula, so it doesn't take much imagination to kind of see two black spots shouldn't be touching and making a connection like that. So that's an enterovaginal fistula. And this is just a standard abdominal ultrasound. So we're not going in the vagina, we're not going, doing anything like that. This is just a plain abdominal ultrasound. And then I haven't done as much training looking at, perianal, anal stuff. There's the Italian group is amazing at doing that, and maybe later on I can go back and do some extra training in that. But you can use ultrasound to look at fistulas as well. So this is just showing an abscess around the bum. So you can see the bum and the anus well if you actually, examine that area, but from the abdomen, it's hard to see that. Oh, that's not the wrong way. Oh yeah, there's an arrow. Perfect. The arrow sign. And then this is somebody who unfortunately has a localized perforation. It's an inflammatory mass, so basically just some kind of stool leaking out into the abdomen. Here's a fistula, so on the left was this fistula, sort of fistula from the terminal ileum to the sigmoid colon. The sigmoid colon comes very close to the terminal ileum, so you can get a fistula there. And then here you can see another stricture with not happy bowel, right? It's just not moving very well. And it's nice when you can show patients this and they have a loop of small bowel that's normal and the abnormal bowel right beside each other. You can just show that. So I'm hoping I've showed you the kind of the utility of doing this for diagnosing people, for following their disease activity, for looking for complications, for predicting relapse, right? When people are feeling well and things are good and you look and you say, I don't know, I'm worried something bad could happen. And then even looking at post-operative recurrence once you've had surgery, following with endoscopy as well instead of doing traditional tests. So we're just going to throw a few kind of fun slides in. So I did the training in Milan in May 2017, the first kind of course, and this is my lovely wife. The trophy next to it is the most beautiful trophy in sports, or Stanley Cup. It's from the Giro d'Italia, the big bike race in Italy. It's just a beautiful gold pink trophy with everybody's name written on it. This is the first kind of group. We were the second group going through getting training. This is Dr. Carrie Novak, who is the leader in Canada doing intestinal ultrasound. And this is where I did my undergrad or my medical school and residency and fellowship. Then I went back to do my ultrasound training. And then I went to Germany in January 2018 to do ultrasound training there. And the ultrasound training the Europeans get is amazing. They're phenomenal. They 3 to 6 months of training for every resident. So cardiologists, gastroenterologists, they all get training in ultrasound. They have ultrasounds in their office. It's a standard test that everybody has. So it's phenomenal. So Erlangen is close to Nuremberg, and Munich, and kind of the south, the fun part of Germany, right, the Bavarian region. It's kind of the center for Siemens Medical. This was one of the 2 sites that had training. So this is just one of the shots of the town. This is the sign going into the hospital, Western University Hospital. This is the team of kind of residents and medical doctors and techs that I work with. Dr. Strobel is the main kind of person over there on the right in the middle. And everybody wears these white uniforms, right? This is like standard wear for German doctors, right? And they don't wear like clothes and like suits like we do, right? They literally get to work, put on these white suits. So first day, first order of business, get the white suit on, right? So went down to the laundry room, got the white suit, got your card so you could eat lunch in the cafeteria with everybody. And that was first order of business, right? So, and then I learned a little bit of German. It's quickly disappeared, all the German that I know. So if anybody speaks German in the crowd, they can kind of read this. But the last sentence there of this is a requisition for an ultrasound in this town, in this university. And I don't want to slaughter the German, but it says, basically the translation says, please intestinal assessment by Dr. Fraser. So that was kind of, it was great that the other GIs that were there knew I was there for a few weeks, and we're sending me a few people. Dermosonography is their ultrasound of the bowel. So we would be getting tons and tons of requisitions, and I would just kind of cherry pick them all day long as I saw bowel ultrasounds. I'd be grabbing them. So, ultrasonography should be a standard tool at IBD centers. There's no question mark after that. I think it should be a standard tool in most IBD centers. And Dr. Gutsy is the German physician here, who the older guy is one of the main leaders in Lüneburg, Germany, doing this. So you say, well, how did you do this? So I'm at 18 minutes, so I think I'm okay. How did you do this, right? So without going into too much of the politics, this is something that I approached our kind of health authority about and our government about. It's going into too many details. The kind of reply was, well, we already have a long wait to get ultrasounds done, giving you time to do ultrasound. We just can't do it, right? So, which is understandable, but a bit frustrating. So, and these machines aren't cheap, right? So some of the portable machines that we have are like $10,000 to $20,000. The ones you see in Emerge are like $30,000 to $40,000. But looking at 2 to 3 millimeter valve, you need a radiology quality machine. So it's about $110,000 for these machines, which in the long term, when you think about it, 10 years, these machines last about 10 years, $10,000 a year. That's nothing, right? Like that's a spit in the bucket. And you do 1,000 exams a year, right? That's nothing compared to everything else that we pay for, CT, MRI, endoscopy, right? This is a very cheap test. So I did a couple presentations to our Ladies Auxiliary, Central Regional Ladies Auxiliary in Bridgewater. I can't speak enough and thank them enough for doing this, but they actually purchased a machine for me for my office. And it's one of the things that I said is, I talked about ultrasound, but I wasn't actually doing it. You can't be a race car driver without a race car, right? you need a machine. So I was so grateful to them when the machine actually came. September 25th, we don't always have champagne in the office, but we did that day. So now it's parked in my office, and I use it continuously. I was on call Wednesday and Thursday this week in the hospital, but I was bringing people down to the office. I was like, I'll meet you there at 3, I'll meet you there at 3:30, right? Because it's so valuable to me now to do it. I've done hundreds of scans now, and I'm really looking forward to doing more. You may see that we were in the news as well, in the CBC, we had an article, a web article, and we were on the actual primetime news talking about it as well. And I wasn't trying to drum up business, definitely was not trying to do that. I was promoting the use of ultrasound, right, and really trying to get it on government's radar, patients' radar, and getting this to be a standard thing that we can all accept whenever we're looking for GI care. And this was a young lady who actually had, unfortunately, a perforation from an endoscopy because she has Crohn's disease. And because her disease was so bad, but she gratefully agreed to come and be part of this article, and she's doing wonderful right now. So we have this Canadian ultrasound group. We argued about the name for a long time, but we eventually called it Can-I Ultrasound. So we've got a great group now across Canada. We had our first meeting in Banff just earlier this year, and one of our main things is education, right? We want to, we have webinars. We just had a webinar recently. We're creating a web portal for images and cases, and then obviously mentoring, other physicians and really promoting this, and hopefully having an IUS meeting this year. Obviously advocacy is one of our big issues too, right? Having patient access for this. Right now, everybody in Canada is doing this out of the goodness of their heart. There's no remuneration, there's no billing code, there's nothing for this. So we're working on that, not because we're greedy doctors, but our time is worth it, and it just legitimizes it as well. And then research, of course, right? Things only improve through research, right? So we want to do quality assurance studies, looking at what we're doing is actually good work, and comparing it to other standard tests and showing, yeah, we can do this, we don't have to do their tests. And then obviously being involved in clinical trials too. So there's already been one clinical trial using ultrasound as an endpoint, and there's 2 other studies. So there's one called Stardust, which is going to be a medication called Stelara, and then there's going to be one called Vido-Sono, which is with obviously vedolizumab. And the very first study was the TRUST study, looking at using Humira or adalimumab with ulcerative colitis and Crohn's disease and using ultrasound as outcomes, which was a great study. And obviously a funny name, TRUST. Do you trust ultrasound? And then this slide I just changed from how will this benefit patients in South Shore, when I presented this to the Ladies Auxiliary, how will this benefit patients in Atlantic Canada, right? So definitely reduce wait time, right, for diagnosis of GI conditions. Endoscopy is, as a member of the Provincial Endoscopy Committee, it's a huge wait time to get in for it. So if we can do this instead and either eliminate the need for endoscopy and take other people off the list so that people can get in, that would be huge. Or finding a diagnosis first and starting to treat it. At the start, I wasn't treating people, but now if I have high suspicion somebody has inflammatory bowel disease and I ultrasound them and it looks like it, I'll start treating them. Reducing or eliminating the need for other tests, cutting down on CTs and MRIs, which are very expensive, and cutting back on endoscopy, which is expensive as well. And then it'll improve treatments because we'll start treatment early, we won't miss things, we'll get it on the ball earlier, and then reducing wait times for everybody else. So these are just web photos; these aren't real patients. That first lady has Crohn's disease. She comes in, has an ultrasound, and you change the treatment right there. You avoid doing a colonoscopy. The next lady you see has a family history of colon cancer. You want to get her in to do her colonoscopy, find polyps or her cancer earlier. So because that first person didn't have a colonoscopy, the second one can. And I just like showing these ones I just found on the internet. So pre-ultrasound, PUS. Well, I'm going to order this test. Once we get it back in a few months, we'll have you come back, and then we'll decide what to do, right? Or you're having some symptoms, let's do the ultrasound today, and we'll make some decisions, right? So, thank you very much. I really do appreciate it. We made it through 300 slides in 25 minutes. That's very good. But thank you so much, Dr. Crohn's. Well, that's a good question. So I've actually had some NPs talk about doing this. In Calgary, they have the best ultrasound techs kind of graduate to do this, right? Because they do, it's more than just doing the scan, right? Like there's more to it than just measuring the kidney size and spleen size and then out the door, right? There's more to it than that, right? So the ultrasound techs in Calgary work with Stephanie Wilson, who's an amazing radiologist, and it's like, if Carrie Novak's the mother, then Stephanie Wilson's the godmother, I guess. She's not the grandmother. So the techs there do it, right? And then the radiologists interpret the images. But even there, they take kind of a mini history, right? And they say, well, what happened since the last time you understand, right? Did you change therapy? Did you up your therapy? Were you on steroids? Did something happen? And they kind of do a mini kind of assessment, because it's not just the scan that's important, it's everything else that goes with it, right? So yeah, definitely technicians do it, right? Gastroenterologists do the question, can NPs do it, right? I mean, if a first-year medical student can do it, I dare say that, any health practitioner can train to do it. But I think the key thing is quality, right? We want to make sure that the people doing it are doing it well, right? And are saving images and quality assurance actually for what they're doing as well. So it's funny, very funny story. So there was a radiologist, I think it was in the UK, wanted to start telling ICU physicians or showing ICU physicians how to use ultrasound. And they said it was too complicated, you can't do it, blah, blah, blah. So she went to a kindergarten class and showed them some ultrasound pictures of normal, abnormal. 95% agreement amongst the children that what was normal and abnormal. So she went back to the ICU and said, well, the 4-year-olds can kind of tell what normal and abnormal, so pretty sure you can. So I think with the proper training, anybody can. And at these courses, we've had technicians and we've had emerge docs as well do it, because there's other applications than just IBD, right? So, yeah, so definitely. But the key thing for gastroenterologists to do it is your patient so well, right? And then you do it at the same time. Your understanding of that image is so much better. And NPs out there are a deal as well. Yeah, in the back.
Did I hear that correct, that the government doesn't pay for that service?
Yeah, so it's kind of slow going. There's lots of things the government doesn't pay, and I don't want to get into too much politics, right? But there's lots of things the government doesn't pay for, right? And you hear news all the time about how low paid Nova Scotian physicians are. I don't know. Anyway, I don't really want to get into that, but there's a process to apply to the government to ask for new billing codes and how we do things. So that process is underway, right? But at the end of the day, like I met a student this week, right? I said, if you want to be a doctor, or if you want to be rich, right? Like there's other ways to become rich, right? If you want to make lots of money, and there's lots of ways to do that. But if you want to take care of people and have a good quality of life, then you'll get paid for what you do. You won't be homeless. But hour for hour, the work you do, I mean, there's other better ways to make money. But no, there's no remuneration right now if you're doing this. Perfect. Thank you so much. I'll see you.